Bismillah ar-Rahman ar-Rahim. Good day, everyone, and thank you so much for watching. I'm Dr. Mahmoud Sheikh, nephrology consultant and World Kidney Academy educator. Today, we will discuss a very interesting and recently published topic, case and KI reports, renal-limited thrombotic microangiopathy without hemolysis, and a typical case. Most of us are trained to think about thrombotic microangiopathy when we see the classic triad of hemolysis, thrombocytopenia, and organ injury. However, this article reminds us that some patients may have severe kidney-limited TMA despite having no obvious hemolysis and sometimes even relatively preserved platelets count. These cases can easily be missed, especially when the presentation appear more like severe hypertension, CKD progression, transplant dysfunction, or unexplained proteinuria or even AKI. The key message is that the absence of cystocytes, normal haptoglobin, or lack of overt hematologic findings doesn't exclude TMA. In many of these patients, the diagnosis depends on maintaining a high level of suspicion and recognizing the importance of kidney biopsy findings. During this presentation, we will review when to suspect renal-limited TMA case, why hemolysis may be absent, and the common underlying causes, and how these changes change our diagnostic and treatment approach. We will even discuss why early recognition matters, because delayed diagnosis may lead to reversible kidney damage and missed opportunities for targeted therapy. So let's get started. When we hear the term thrombotic microangiopathy, most of us immediately think about the classic systemic picture. We think about thrombocytopenia, microangiopathic hemolytic anemia, schistocytes, elevated LDH, low haptoglobin, and obvious in-organ damage. In other words, we are trained to recognize TMA when the blood is already telling us the story. But renal-limited TMA is different. Renal-limited TMA is much quieter, much more subtle, sometimes much more dangerous because it hides behind other diagnoses. The patient may not have severe thrombocytopenia. The patient may not have obvious hemolysis, and the blood smear may be normal. The LDH may be only mildly elevated or even normal. Because of that, many clinicians may falsely reassure themselves that this can't be TMA. But the kidney may already be suffering from ongoing endothelial injury, microvascular thrombosis, ischemia, or irreversible nephron loss. That's why renal-limited TMA is truly a diagnostic challenge. It often appears in settings where there are already many competing explanations for kidney injury. For example, in GN, we may blame worsening kidney function on active inflammation. And in transplant patients, we may think first about rejection, CNI toxicity, BK virus, or chronic allograft dysfunction. During pregnancy, we may focus on preeclampsia, HELLP syndrome, or volume depletion, or ATN. In autoimmune disease, infection, malignancy, or drug exposure, there are often many overlapping possibilities that make diagnosis even more difficult. Philosophically, renal-limited TMA teaches us an important lesson. Disease doesn't always read the textbook. Sometimes the body gives us only whispers before it gives us a big scream. If we wait for the classic picture of systemic TMA to appear, we may miss the narrow window where the kidney can still be saved. This is why kidney biopsy becomes so important. Sometimes the biopsy is the only place where the disease is speaking clearly. In this case, the biopsy revealed complement-mediated renal-limited TMA in a native kidney, despite the absence of systemic features or precipitating factors or peripheral evidence of TMA. That means there were no obvious clues in the blood, no major triggers, and no classic hematologic pictures. Yet, the kidney pathology clearly showed that TMA was present. This is exactly why correct identification matters. Once we recognize the disease properly, we can move toward disease-modifying therapy before permanent kidney damage occurs. The lesson from this slide is very simple. The absence of hemolysis doesn't exclude TMA. The absence of thrombocytopenia does not exclude TMA. And also sometimes the kidney biopsy sees what the blood cannot see. Let's start with this patient. This is a 55-year-old man with well-controlled hypertension or lisinopril and a background of chronic normostatic anemia. At first glance, this doesn't sound like dramatic TMA presentation. There is no severe hypertensive crisis, there is no obvious thrombocytopenia, and there is no overt hemolysis. In fact, the patient was referred mainly because of mildly elevated serum creatinine of 1.49. His hemoglobin was 12.5, which is only mildly reduced, and could easily be dismissed as chronic anemia or anemia of chronic disease. The workup for hemolysis was unrevealing. There was no major lab clue pushing the clinician toward TMA. The monoclonal workup was also negative. making paraprotein-related kidney disease is less likely. When we look deeper into health history, we find intermittent microscopic hematuria going all the way back to 2005. That is very important because it tells us that this may not be an acute process. This may be chronic, smoldering disease that has been affecting the kidney silently for years. He also had mild proteinuria between 2012 and 2014 with an albumin to creatinine ratio of 158 milligram per gram, but later this also resolved. Again, this is subtle. Mild proteinuria plus microscopic hematuria are very common findings in nephrology, and many times they are attributed to hypertension, mild CKD, or even ignored completely if kidney function is relatively preserved. He has also underwent a negative urologic workup, including cystoscopy and imaging. That is very important because once the common urological causes of hematuria are excluded, we should start thinking more carefully about GN or vascular causes. Philosophically, this case teaches us that the kidney disease often develops quietly. The kidney rarely complains loudly in the beginning. Patients may have years of microscopic hematuria, mild proteinuria, or even slowly rise creatinine before the real diagnosis becomes visible. Sometimes we are waiting for a dramatic lab abnormality, but the disease is moving forward in silence. This is exactly the type of patient who can be easily missed. Mild creatinine elevation, mild anemia, no hemolysis, negative initial workup, but behind all of this may still be ongoing endothelial injury and chronic renal-limited TMA. The key lesson here is that when abnormalities persist for years without a clear explanation, we should resist the temptation to label them as a benign. Sometimes subtle findings repeat over time are more important than one dramatic abnormal results. Okay, let's see the progression over time. At presentation, the abnormalities were still relatively mild. The urine protein to creatinine ratio was only 0.22 milligram per gram per milligram. And the estimated GFR was around 55. Again, this is exactly the type of patients many clinicians might choose to observe rather than aggressively investigate. The serologic workup for renal dysfunction was unrevealing. There was no convincing evidence of lupus, vasculitis, paraproteinemia, or infection-related GN, or any other obvious systemic process. Because of chronic anemia, the patient even underwent bone marrow biopsy. But the bone marrow biopsy were essentially normal. It showed normal cellular marrow with heterogeneous hematopoiesis, adequate iron stores, normal cytogenetics. In other words, despite multiple investigations, there was still no unifying diagnosis. This is not one of the easy cases, and this is one of the most frustrating situations in nephrology. The patient clearly has abnormalities, but every test seems to come back non-diagnostic. Over time, however, the pattern began to change. The creatinine increased further to 1.6. The 24-hour urinary protein increased to 681 milligram, and the hemoglobin dropped further to 11.2 over only 3 months. None of these findings alone are dramatic, but together they tell us an important story. The kidney function is worsening, the proteinuria is increasing, and the anemia is progressing. This is not stability, this is progression. That is a critical point. In nephrology, we shouldn't only focus on how abnormal a number is, we should also focus on direction of change. Creatinine of 1.6 may not seem very high. Proteinuria of less than 1 gram per day may not seem severe. Hemoglobin 11.2 may not seem alarming. But when all of these are moving in the wrong direction over a short period of time, they become much more meaningful. Philosophically, this is where trend matters more than the snapshot. A single lab value is like one frame from a movie. But when we step back and look at the sequence over time, we begin to see the real plot. This is a progressive pattern was the trigger for kidney biopsy. In retrospect, the biopsy became the turning point in this case. Without the biopsy, the patient may have continued to be labeled as having non-specific CKD or hypertension-related kidney injury or unexplained anemia. Instead, the biopsy revealed the hidden diagnosis that none of the blood tests has been able to show. Going to the kidney biopsy, which is really this case becomes clear after. On light microscopy, there is segmental mesangial which means there is structural damage, dissolution within the mesangial support framework of the glomerulus. We also see swollen endothelial cells and expansion of subendothelial space. This is very important because endothelial injury is one of the hallmarks of thrombotic microangiopathy. The glomerular basement membrane is no longer smooth and uniform. Instead, it shows thickening, remodeling, and double contour formation. Double contours are especially important because they suggest repeated cycles of endothelial injury and repair over time. In other words, this is not a sudden event. This is chronic smoldering process that has likely been evolving silently for years. On immunofluorescence, there are sparse T3 deposits in what is described as starry sky pattern. This is important clue because it suggests activation of complement pathway. But the deposits are relatively limited. This is not the heavy immune complex pattern we might expect in lupus nephritis or MPGN. Instead, it's more subtle, more compatible with complement-mediated endothelial injury. The electron microscopy gives even more detail. We see widening of subendothelial space with flocculent debris. Again, this reflects ongoing endothelial damage. There is also marked remodeling of the GBM, confirming that this injury is chronic rather than an acute event. In addition, there are mesangial and small subepithelial electron-dense deposits. These deposits are important because they may create some diagnostic confusion. At first glance, someone may think about immune complex disease, chronic GN, or even atypical membrane liposis. But when we put all biopsy findings together, the dominant picture is still endothelial injury with chronic TMA-like remodeling. Philosophically, pathology is sometimes like reading the hidden story of the disease. The blood test only shows us what is happening today, but the biopsy shows us what has been happening over many months or years. The double contours, the endothelial swelling, the mesangiolisis, and subendothelial lucency are all signs that the kidney has been fighting this injury for a long time. This is why biopsy is so powerful. It allows us to see the story that the lab values can't be tell. And in this patient's story strongly points toward chronic renal-limited complement-mediated TMA. So, when we put all of these findings together, the final diagnosis becomes much clearer. This is not a primary glomerulonephritis, this is not diabetic nephropathy, and this is not simple hypertensive nephrosclerosis. This is not non-specific CKD process. The dominant pattern is chronic endothelial injury involving the glomerular microvasculature. The C3 dominant staining suggests that the alternative complement pathway is playing a major role in driving this injury. In other words, the complement system appears to be activated in an abnormal and persistent way, leading to ongoing endothelial damage inside the kidney microcirculation. Over time, that endothelial injury becomes chronic remodeling, vascular narrowing, ischemia, and progressive loss of kidney function. That's why diagnosis here is complement-mediated thrombotic microangiopathy. More specifically, this is renal-limited TMA, complement-mediated. The disease is confined mainly to kidney without the classic systemic manifestations we usually expect, such as severe thrombocytopenia, marked hemolysis, or widespread organ injury. This is exactly that makes the diagnosis so challenging. Most clinicians are trained to think TMA as hematologic emergency, but this case reminds us that sometimes TMA behaves more like a chronic kidney disease that quietly progresses in the background. Philosophically, this diagnosis teaches us something very important. Not every dangerous disease is loud. Some diseases move slowly, hide behind common diagnoses, and reveal themselves only when we look deeply enough. This patient didn't have the classic pictures of DTB. He didn't have the dramatic presentations of atypical HUS. Instead, he had a silent form of complement-mediated vascular injury that was confined to the kidney. If the biopsy has not been done, the true diagnosis would probably have remained hidden. The most important message is that unexplained progressive CKD with subtle urinary abnormalities and unrevealing blood work should sometimes raise suspicion of renal-limited TMA, especially when the biopsy points toward chronic endothelial injury and complement-mediated activation. After the biopsy suggested complement-mediated TMA, the next step was to understand why this patient developed this disease. The complement testing gave another very important clue. ADAM-TS13 activity was normal, which makes TTP much less likely. There was no infection identified, no monoclonal protein, and no secondary trigger that could easily explain the TMA. The major abnormality was low C3 and normal C4. This pattern is very important because it points toward activation of the alternative complement pathway. In other words, this is not the classic complement consumption pattern we often see in lupus or immune complex disease. Instead, it suggests dysregulation of the complement system itself. The genetic panel then made the diagnosis even stronger. The patient has a pathogenic C3 variant. This means that one of central proteins in the complement cascade is genetically abnormal and more likely to remain activated. Once complement becomes inappropriately activated, it can continuously attack the endothelial surface of BM and microvasculature. That leads to chronic endothelial injury, thrombosis, ischemia, progressive kidney damage, and this patient has had also homozygosity for CD46, also known as MCP, risk haplotype. CD46 normally acts like a protective brake that prevents complement from damaging the body's own cells. If the protective brake is weaker, the kidney becomes more vulnerable to uncontrolled complement activation. In addition, he carried CFH-H3 haplotype, which is another major risk factor associated with more severe form, higher penetrance, worse kidney outcomes. So this patient doesn't have just one abnormality, he had multiple complement-related risk factors acting together. This is an important concept. Many kidney diseases are not caused by one single mutation or one isolated event. Sometimes the disease develops because several small vulnerabilities align at the same time. One abnormality increases susceptibility, another increases severity, another removes protection. Together, they create the perfect environment for disease to appear. This also explains why some patients remain subtle for years and then suddenly worsen. The genetic predisposition may be present for decades, but the clinical disease only becomes visible when the cumulative burden finally crosses a threshold. One very important practical point is that no C5 resistance variants were identified. That matters because it means the patient would still be expected to respond to C5 targeted therapy such as eculizumab, ravulizumab, and at the end, the complement profile genetic testing didn't just confirm diagnosis, they also help explain not only confirming the diagnosis, they also explain the mechanism of disease and guide the choice of treatment. Going to the treatment and response, once the diagnosis of complement-mediated TMA Renal-Limited was established, the treatment was directed toward blocking the complement pathway. The patient was started on eculizumab on April 2025. This is a very important step because in complement-mediated TMA, the main problem is uncontrolled activation of the terminal complement cascade. By blocking C5, we can interrupt the downstream inflammatory and endothelial injury process before more irreversible kidney damage occurs. One important point in this patient is that there were no major peripheral TMA markers to follow. There was no severe thrombocytopenia. There was no marked hemolysis. Unlike classic TTP or systemic atypical HUS, we could not rely on platelet count or LDH schistocytes to monitor treatment response. And instead, the main markers of disease activity became kidney function and hemoglobin. After treatment, the creatinine improved to 1.3. The T3 level also increased from 47 to 51. Even though that change may seem small, suggests at least partial improvement in complement consumption. Most importantly, the patient showed renal stabilization and early renal recovery. Later, the patient was transitioned to ravulizumab for ongoing long-term therapy. Ravulizumab works through the same pathway as eculizumab but has much longer duration of action, allowing less frequent infusions, making chronic treatment more practical. The goal of long-term C5 inhibition is not only to improve creatinine in short term. The larger goal is to prevent ongoing endothelial injury, reducing chronic scarring, delaying or prevent progression to end-stage kidney disease. Another very important practical point is that meningococcal vaccination was complete before starting therapy. This is essential because blocking terminal complement increases the risk of severe meningococcal infection. Treatment in this case is not simple about making the lab numbers look better. It's about changing the future of the disease. Without treatment, the patient would likely continue to accumulate silent endothelial injury over time. With complement blockade, this is now an opportunity to slow the disease, preserve kidney function, and potentially avoid dialysis for many years. So, why was the diagnosis delayed? One of the most important questions in this case is, why was the diagnosis delayed for so many years? The answer is simple. This patient never developed the classic picture of systemic TME. As we mentioned before, there was no severe thrombocytopenia, there was no obvious microangiopathic hemolytic anemia, there was no dramatic schistocytes, no severe LDH elevation, no sudden catastrophic decline. Instead, the disease progressed very slowly and quietly. The patient only had mild anemia, mild creatinine elevation, intermittent microscopic hematuria, and low-grade proteinuria. Those are findings that many nephrology patients have. Naturally, it's very easy to attribute them to hypertension, aging, chronic kidney disease, or even non-specific vascular disease. That's exactly why renal-limited TME is so difficult to recognize. The disease often hides behind very common diagnosis. Another reason for delay is that complement-mediated TME is rare. Many clinicians may go through their entire careers without seeing a confirmed case. When the disease doesn't fit the classic textbook picture, it may not even enter the differential diagnosis. The other important concept is that complement-mediated TME is often multifactorial. About half of cases involve inherited pathogenic variants, but those variants alone are often not enough to immediately produce disease. Many patients have incomplete penetrance. In other words, they carry the risk for years or even decades without developing the overt pattern. Then, over time, multiple factors align. One genetic abnormality may increase complement activation. Another may reduce complement regulation. Another may increase disease severity. Together, they create the perfect biologic environment for endothelial injury. This is often called the second hit concept. A person who has genetic predisposition from birth, but the clinical disease may only appear later after hypertension, aging, inflammation, pregnancy and infection, drugs, and other stressors pushes the complement system beyond its limit. In this patient, the combination of pathogenic C3 variants, CD46, also known as MCP, homozygosity, and CFHH3 heterozygosity, created a very high-risk background. This case reminds us that disease is often not caused by one single event. Sometimes disease appears only when several small abnormalities quietly cooperate with each other over many years. This is why we should always be careful when a patient has persistent unexplained kidney abnormalities that not fit to the diagnosis. Sometimes the delayed diagnosis is not because the disease was absent. Sometimes it's because the disease was hidden. The good news is that complement-mediated TME is no longer the devastating disease it used to be. Historically, before complement inhibitors became available, many patients progressed to end-stage kidney disease or died within only a few years. In some high-risk genetic groups, especially patients with CFH mutations, the risk of end-stage kidney disease or death reached very high levels. The introduction of eculizumab changed that completely. Clinical studies have shown that nearly 2/3 of patients can achieve complete TME response within about 6 months of therapy. That means improvement in kidney function, stabilization of hematologic parameters, and interruptions of chronic endothelial injury process. Rather than simply slowing disease, eculizumab can fundamentally change the trajectory of the illness. One of the biggest ongoing questions is how long treatment should be continued. Some studies suggest that carefully selected patients may be able to stop therapy safely within very close monitoring. In the CURE-IH-US study, a small proportion of patients relapsed after early withdrawal. But importantly, they responded quickly when treatment was restarted. However, renal-limited TME creates a special challenge. These patients often don't have clear blood markers that can warn us when the disease is becoming active again. They may not develop thrombocytopenia or hemolysis before kidney injury progresses. That means relapse can remain silent until creatinine rises again or more kidney damage are already occurred. Because of that, stopping therapy may be riskier in renal limb disease than in patients with more obvious systemic TME markers. In this patient, the genetic background is also important. He carries a pathogenic C3 variant and high-risk complement-related haplotypes. That means his risk of recurrence and progressive disease is likely higher than average. This is why ongoing long-term C5 inhibition with ravulizumab is probably the safest strategy. Another important point is transplant planning. If this patient eventually reaches end-stage disease, the genetic profile matters greatly. Patients with isolated CD46, also known as MCP, abnormalities may often be relatively well after transplantation because the donor kidney can provide normal complement regulation. But patients with circulating complement abnormalities such as C3 or CFH mutations have much higher risk of recurrence after the transplantation. Those patients often need continued complement blockade even after transplantation. The goal of treatment is not just to rescue the kidney today, it's to protect the kidney of the future. In disease like complement-mediated TME, every month of controlled complement activity may represent months or years of preserved kidney functions later on. To conclude, this case leaves us with several very important teaching points. First, thrombotic microangiopathy doesn't always present with classic picture of hemolysis and thrombocytopenia. Sometimes the disease is confined mainly to the kidney, presents only with hematuria, proteinuria, slowly progressive CKD, or even unexplained anemia. Second, in renal-limited TME, the traditional hematologic markers may be absent. That means we have to monitor kidney-specific parameters more carefully. Renal function, urine analysis, proteinuria, hemoglobin trends, complement levels may be more informative than platelets or LDH. Third, the central mechanism in this disease is dysregulation of alternative complement pathway. Once that pathway becomes uncontrolled, chronic endothelial injury develops inside the glomerular microcirculation. Fourth, genetic abnormalities rarely work alone. Multiple complement-mediated variants may interact with each other in synergetic way. One abnormality may increase complement activation, another may weaken complement regulation, another may increase disease severity or recurrence risk. Together, they shape the final clinical picture. Fifth, genetic testing is not only diagnostic, it's also therapeutic. Helps us to predict who is more likely to respond to complement blockade, who is at higher risk of relapse, and who may need long-term therapy. It also helps identify patients who may not respond to C5 inhibition because of resistant polymorphism. Finally, the question of treatment duration remains one of the most important unresolved issues. Historically, lifelong C5 inhibition has been considered standard for many patients, but future management may become more individualized based on genotype, disease severity, relapse risk, and the ability to monitor disease activity safely. This case reminds us that medicine is not only about recognizing patterns, it's also about recognizing when the pattern is incomplete. Sometimes the absence of classic features in itself the most important clue. Sometimes the diagnosis we miss is not the rare diagnosis we never thought about. It's the rare diagnosis that quietly looked like something common. The most important clinical takeaway from this case is that we should not wait for the full classic picture of TME before acting. If the patient has unexplained kidney dysfunction, persistent hematuria, mild proteinuria, or slowly progressive anemia, or worsening creatinine without clear explanation, we should maintain high level of suspicion. Even if there is no typical thrombocytopenia, if there is no overt hemolysis, even if the blood smear is normal. In these patients, early kidney biopsy can be the differential between finding the diagnosis and missing it completely. Once chronic endothelial injury becomes advanced, some of the kidney damage may no longer be reversible. That is why early biopsy is so important. We should not wait for systemic signs to appear before investigating further. The second important message is that genetic testing matters. Identifying complement-related variants can help explain why the disease developed, estimating the risk of progression, and guide our treatment decisions. Genetic testing is no longer just an academic exercise. It is becoming part of practical, personalized nephrology. The final point is that targeted therapy can truly change outcomes. C5 inhibition is not simply supportive care, it directly interrupts mechanism cause endothelial injury. In many patients, it can also preserve kidney function, slow progression, reduce recurrence risk, or prevent dialysis. This case reminds us that kidney often gives quiet warning signs long before it gives dramatic ones. The challenge for us as nephrologists is to recognize those early whispers before they become irreversible damage. Early biopsy, early genetic testing, early targeted therapy. That's how we save kidneys. Thank you so much for watching. I hope this lecture was helpful and easy to follow. If anything was unclear or if you have any questions, please don't hesitate to reach out to me. I would be very happy to discuss any part further. Thank you again and look forward to see you in the upcoming lectures. Assalamu alaikum wa rahmatullahi wa barakatuh.